I'm going to be talking about anti-neutrophilic cytoplasmic antibody-associated vasculitis and what is the role of ECMO in this disease. So I came across this case in my second year, and Dr. Harsimranpreet Singh was my senior, and he assisted me in this poster. So just a brief introduction before I start my case. ANCA-associated vasculitis can present with various signs and various symptoms, generally with sinusitis. It affects the kidneys and affects the pulmonary symptoms. But in this patient, and in this particular case, patient presented with diffuse alveolar hemorrhage, which was the first sign or the first symptom that he had. So the first point is that diffuse alveolar hemorrhage can be the first presenting symptom in patients with vasculitis. Historically, when I looked at the literature, patients like this had a case fatality which was as high as 50%, and traditionally they were generally managed on mechanical ventilation. Now, ECMO has emerged as the next critical intervention in patients who continue to have respiratory failure despite being on the conventional mechanical ventilation. This is an abstract which highlights the role of ECMO in these patients particularly. So my case begins, this is a 68-year-old male, and patient was fairly active at baseline. I saw him for the first time in the emergency room. At that time, he came with dyspnea and persistent hemoptysis, which he was having for the last 4 days. All other questions were negative, like no sinusitis, no joint pain, no kidney problems. These were the only two pertinent positive findings. On physical examination, the physical examination was positive. The patient was hypoxic and he was requiring high flow nasal cannula with 100% FiO2. He was using accessory muscles of respiration. Bilateral chest crackles were heard. There was no lower extremity edema. There was no joint swelling. We quickly sent the blood work and did a bedside echo. The bedside echo suggested that left and the right ventricle were hyperdynamic, like the systolic and function was normal, the ejection fraction was normal. So, and then the IVC was collapsible. By the time the lab results came back, and it showed that patient had hemoglobin of 8, which is low for a middle-aged male. There was no leukocytosis, procalcitonin was normal, COVID-19 testing was also negative. The next step we chose was to do a CT scan with contrast, which further showed that patient had bilateral opacities, and there was no PE that was noted. By this time, we continued to manage the patient with everything that we could do, and then he continued to have increasing oxygen requirements, and within the next 24 hours, he required to be intubated. Next, we proceeded with bronchoscopy, and bronchoscopy was consistent with diffuse alveolar hemorrhage. There was no large airway bleeding that was noted. Patient was at this point is intubated. Patient is now brought to the ICU and is being closely monitored. However, despite maximum mechanical ventilation effort, he continues to be hypoxic. Now, on repeat examination, we see that the patient, along with the crackles, also has some diminished breath sounds. At this time, we attempt with pronation. Pronation helped with oxygenation slightly, but not to a great effect. Now we are scratching our head and we are thinking of all the differential diagnoses. At this point, we feel there's a very low likelihood of infectious process. There was no fever, no leukocytosis, and all of this sudden presentation is not consistent with pneumonia. We ruled out heart failure by doing an echocardiogram. Our working diagnosis at this point was an inflammatory process, and we started the patient on pulse dose steroids, and autoantibody panels were sent. We tried our best to maintain him on the mechanical ventilation. However, he continued to deteriorate. So we quickly decided to transfer the patient to a facility which had ECMO. So I'm coming from a community hospital, and we only have one ECMO, and that's reserved for patients like who go for the cardiac patients. So we did not have the VV ECMO facility. So we decided to transfer the patient to a hospital with VV ECMO facility. Patient was successfully transferred. So what did we see on follow-up? On following up with the attending at the other hospital, we found out that patient was maintained on VV ECMO for 5 days, and then he was successfully weaned off the oxygenation. Patient was maintaining oxygen after that. By the time PR3, the anti-proteinase 3 antibody panel was positive, and it was more than 177, which confirmed our diagnosis. Unfortunately, on the 6th or 7th day, patient suffered from a cardiac arrest and passed away. So coming to the discussion part of this topic, what are the three main things that I learned and would like to present to my audience? Number one, what is the role of ECMO? So ECMO provides valuable time for the immune modulating therapies to take effect. So it's not going to cure the disease, but it does give us some time. It buys us some time for the medication to act. This is and the second step, the second big thing that I learned, and like if you're in a community hospital and you don't have the facility, we need to transfer the patient early because every patient deserves the best care. So early referral should be considered. Third thing is there are like two types of ECMO, VV ECMO and VA ECMO. So VV ECMO is the one that is generally considered in patients who have respiratory failure, but the cardiac or the heart is functioning normally. This is the image that I included here. A large vein is utilized, and then the blood is pumped to a membrane oxygenator, and then after oxygenation, the blood is put back into a large vein. In VA ECMO, however, it's generally utilized when heart and the respiratory system both require support. So in the end, I'll just say that I was actually going through all the trials and all the studies that have been done in patients. ECMO has been utilized, although but I could not find any trials, in particularly in vasculitis patients, but I could find 4 or 5 case reports, and all of them had positive outcomes, and then case studies too. So I think I don't know if it is possible to conduct a big trial because this is not a very common presentation, but looking at all the case reports, I think ECMO has a role in vasculitis patients. These are my references, and I have no disclosure of interest. Thank you.